David, thank you for the kind introduction. To the audience, thank you for hanging out till the bitter end. It is really my distinct honor to give this lecture. 40 years ago, the first nucleoside drug with anti-HIV was described. For those of you that, unlike myself, may not have been around at that time. And this audience well understands the dramatic progress that has been made in drug discovery and the application of drugs to treat HIV. Mortality data from the United States for the 5 leading causes of death show that only HIV disease has had this precipitous decline, and it's simply because of new drug discovery and understanding new ways to give these drugs. As good as therapy is, we know there are some limitations to antiretroviral therapy. Most importantly, it does not cure it. In persons with sustained, even persons with sustained suppression, you do not fully restore the immune system, completely bring the body back to normal health. Evidence supports that there are at least 2 distinct but not mutually exclusive reservoirs. The latent reservoir comprised of infected lymphocytes in a quiescent state, and a bit more controversial, a reservoir of low-level ongoing replication. The bulk of virus, 98 or more % of it, resides in the secondary lymph nodes in the gut-associated lymphoid tissue. And when one looks at the mechanisms that allow drug penetration into those sites, it doesn't favor, of our current antiretroviral drugs, uniformly high penetration. So we have been interested in reservoir sites for some time, really turned our focus into the lymphoid tissues in the GALT in around 2009, 2010. And our first prospective studies, starting here on the far left-hand side, was a group of individuals who we started on, and they were antiretroviral therapy naive. We started them on antiretroviral therapy and looked at the decline in HIV RNA in the lymph node. So they all achieved undetectable levels of HIV RNA in plasma, and this slide shows you the decline in the lymph node. And you can see about half read the book. Their lymph node concentrations of HIV declined just like their plasma did, but that was not uniformly seen. There were individuals who declined and plateaued. There were individuals who declined and rebounded. Again, all in the setting of maintaining suppressed levels of HIV RNA in plasma. In the top right-hand corner of this slide, is a collection of work where we've looked at the ratio of antiretroviral drugs in lymph node mononuclear cells and referenced it to the ratio, to the concentration of those drugs in peripheral blood mononuclear cells. And the line drawn at 1 would reflect equal concentration in lymph node cells as in PBMC cells, and you'll see that is not usually the case with the collection of antiretroviral drugs that we use. And the bottom right-hand part of the slide simply shows for these individuals that we studied in this paper, we simply characterized whether their lymph node decay of virus was rapid or whether it was slow, and did you have high concentrations in the lymph node or low concentrations in lymph node cells, and not surprisingly, those with slow decay had low concentrations. So as a framework, it's useful to lay out some guide. How are we going to understand these problems, and to lay out some principles that you can hopefully get some agreement on, and that allows you to test various ideas, studies as you go forward. So these are our current or my current heuristics for studies of active reservoirs. First, if you have an active reservoir, it's going to be a barrier to full reconstitution of the immune system. I don't think that's a controversial principle. I think people would buy that. If you have persistent virus in plasma, that likely reflects true viral production from clonal expansion only, I think, if you can rule out adherence and any pharmacokinetic, pharmacodynamic issues. Couple of side bullets on that are we confident we can measure long-term 100% adherence? And are therapeutic concentrations in the plasma reflecting therapeutic concentrations in cells and in tissues? If residual viremia is not due to viral replication, then antiretroviral or ART therapy, optimization or intensification should not produce any virologic or immunologic changes. And lastly, are all ART regimens that achieve full suppression in the plasma equally potent in stopping infection in new cells? Sub-questions would be, if ART regimens are equally potent, then there should not be differences in DNA or RNA in tissues. And how do we determine the potency of ART regimens? So I'm going to show you now three bits of our more recent work, and think about these principles, these heuristics, as we go along. So this is a publication that's now available online. Excuse me, in eLife. Was a collaboration with a group in Belgium, and we studied dolutegravir intensification in individuals with suppressed viral load. Simply doubling the dose. Half maintained the usual dose of dolutegravir, and in half the participants, we doubled their dose. As I mentioned, they were all already fully suppressed in plasma and had been for some period of time. We collected plasma, peripheral blood mononuclear cells, and the compartment that we chose to study here were rectal biopsies, and they were samples were collected at different time points over this 3-month period of intensification. Virologically, we measured total HIV DNA, intact DNA, unspliced RNA, all in PBMCs in tissues. And antiretroviral concentrations were determined in plasma and in and in the tissues. So one of my criticisms, and some of you have probably heard me talk about this with intensification studies, is rarely do we show a change in concentrations at the site where there may be viral replication. So from a pharmacologic point of view, if you don't change those conditions in the place where the virus is replicating, you're really not doing an intensification study at all. So to try to make sure we lived up to what our criticism, or at least my criticism, has been, this slide shows you concentrations in the rectal tissues. In the control subjects, you can look at day 0, day 84. While there is a little more variability on day 84, and we're really not sure why that is, there is no overall change in rectal DTG, dolutegravir concentrations. On the right-hand side of the slide, though, in the persons who got the double dose, we see them at baseline, and then you see them at day 84, and there is the expected change in rectal tissue concentrations. So we did change the pharmacologic conditions in that compartment. So here are some measures of longitudinal dynamics. On the left is total HIV DNA and PBMCs, and on the right, unspliced HIV RNA in PBMCs, and this looks at the change over time, with the blue line being the intensified group, the red line the control group. It's fairly subtle, I will say, with HIV DNA, but it is statistically significant over time that it does decline in the intensified patients. A little more clear cut, I think, with the unspliced HIV RNA over time on the right, that again, it stays the same in the placebo recipients and declines in the intensified group. So some observations or conclusions from this: no difference in plasma concentrations between the intensified and control group. The tissue concentrations did increase, and I've said this should reflect we changed pharmacologic conditions in that compartment. We saw decreases in DNA and RNA. I'm not showing you the data. There was also reductions in some of the other immune markers, and these results to us suggest that viral intensification did result in changes of markers of replication, which you would take to mean there was ongoing replication in these persons who had been suppressed in plasma. The second study that I want to highlight now is the central nervous system, and specifically the cerebral spinal fluid. This had been an early interest of ours, and we kind of set it aside when we really started to focus on lymphoid tissues, but have come back with some recent work. This is with the AIDS clinical trials group, where we looked at cerebral spinal fluid levels, measures of viral persistence, and with assessments of cognitive function. These are participants who'd been on ART for at least 2 years with well-documented sustained suppression. We had CSF and plasma levels, cell-associated HIV DNA in CSF, and inflammatory biomarkers. The ARV levels were measured in our laboratory. We applied population PK modeling. Sean Avedisian, who's in the room, did that. That paper has now been published, and it's referenced at the bottom of the slide. One of the things I think most of us in this room at some point have grappled with is this question of how do we assess the potency of a regimen? Not of a drug, but of the regimen that we're giving the patient. And many of us have come to the inhibitory quotient as a way to try to get at that question, because it reflects how much you have, drug concentration, to how much you need, what is that inhibitory concentration. And here we applied that principle and calculated the IQ of each individual drug in a patient's regimen, and then took the geometric mean of those 3 or 4 or whatever it would be, drugs, as then a marker of regimen potency, and then use statistical analysis to evaluate what I'm going to call the ART IQ and the CSF HIV DNA, and then the global deficit score, which is a measure of neuropsychological assessment of cognitive function. And this is a summary slide of that. 44 participants. This group, they were all on the same nucleoside backbone of tenofovir and FTC. And the third drugs ranged, as shown on this slide, efavirenz to protease inhibitors to integrase inhibitors. And we found that a higher ART IQ measurement was associated with lower global deficit scores. So in other words, better neurocognitive function. So the higher the ART regimen, let's call it potency, was associated with better neurocognitive or global cognitive function. There was no association with the inflammatory markers. And then the picture graph on the right shows you that this ART mean score was associated with CSF. The higher the ART score, the greater the likelihood of not detecting CSF HIV DNA. So the most recent and not yet submitted work, but we're close to it, that I decided if I was ever going to share this, this would be the audience that I would be appropriate to share these data with. This is a study looking at losartan in antiretroviral in patients taking antiretroviral therapy to assess overall immune reconstitution. Most of you will know or remember that losartan's an angiotensin II receptor blocker. It inhibits TGF-beta, and it's been associated with reductions in fibrosis in the liver and the heart, as well as the kidney. And our objective was then to investigate whether it could improve the lymph node architecture. I think you know that the lymph nodes are a target organ for HIV. There's high levels of collagen deposition, and it fundamentally changes the architecture of the lymph node. And that does not resolve even over long-term antiretroviral therapy. It may improve, but it doesn't resolve. So we designed a double-blind, placebo-controlled 30-month trial of losartan versus placebo, 52 individuals. We used a 100 milligram dose, the standard dose of losartan. and then assess the impact on lymphoid tissue fibrosis, CD4 cell populations, viral reservoirs, intracellular drug concentrations, immune activation. We measured, I think, most about everything that we could possibly measure. These individuals came in to the study suppressed, long-term suppression on an ART regimen, so all less than 48 copies per mil. As I mentioned, the losartan dose, and specifically, I'm talking about the lymph nodes. We collected those at 3 time points: at baseline, at month 12, and then at month 30. So I'm going to jump right in and show you first some of the measures of immune reconstitution results. These are, three markers: IL-6, IL-8, and IL-10. You see the placebo group on the left of each of those panels, losartan group on the right. And over this 30-month trial, you can see these inflammatory biomarkers tended to increase in the placebo groups. Remember, it's placebo losartan, but they maintained their antiretroviral therapy throughout this whole 30-month period of time. And then the far right shows you the change in IL-10, and it's that same pattern, an increase in the placebo group, and actually a slight decrease in losartan recipients. So there is evidence that these markers of immune reconstitution did change over time. We looked at viral RNA, the number of cells in the lymph node, again, over this 30-month period of time. This slide shows you the change in RNA, viral RNA over the 30-month. It went up in the placebo group versus staying the same, maybe slightly decreased in the losartan group. And try to walk you through this, a summary slide of measures of antiretroviral levels in the lymph node. So tenofovir diphosphate concentrations, blue are the losartan recipients, orange are the placebo recipients over the 30-month FTC triphosphates. And then I'm just showing you the third ARV concentrations at month 0. So a couple of patterns that I think you can, at least we picked up, and that were surprising to us. Starting with tenofovir diphosphate, we see an increase in tenofovir diphosphate concentrations over the 30-month period of time. We see an increase in the FTC triphosphate concentrations over the 30-month period of time. The third ARV becomes a challenge because we allowed the regimen to be changed over the 30-month period of time. So some of you may have noticed we had a fair number starting on efavirenz. Most of our clinics, we have moved away from efavirenz. We moved to, in some cases, protease inhibitors and integrase inhibitors. So I'm going to come back to this ART-IQ score. Some of the features of that ART-IQ score were, one, it would allow changes in antiretroviral regimens over time, because the way you normalize it to the regimen is the same. You simply calculate the IQ. So if a drug changes, we simply recalculate what the IQ of that drug was over time. And this score would also allow for time varying. So if something changes in the concentrations of those drugs over time, this ART IQ score is also able to capture that change over time. So we reasoned that if we can apply this to the CSF, as we did in the study I showed you earlier, there's no reason we can't apply this to another compartment, and so we did the same thing. And these are the results now of the ART IQ score at 0, 12 months, and 30 months in the lymph node, in the losartan and placebo recipients. This trend then continues over the 30-month period of time for those that received losartan to increase, and for those that received placebo to actually have a decrease. And these differences by month 30 are significant. Just as a point, at month 12, had we done only a one-year study, we would not have found this. So this is a long-term change that we're seeing. So anyone out there working in the oncology field may be familiar with some of these data. Losartan for some time has been of interest to the oncologists as an investigational strategy to improve drug penetration into tumors. And I've picked just three of a collection of literature that's available. That it does inhibit collagen, that solid stress impairs lymphocyte infiltration and lymph node metastases. Losartan is associated with decreasing stress, and that an angiotensin inhibitor enhances drug delivery by decompressing tumor blood vessels. Things that should apply to trying to get antiretrovirals into, in our case, lymphoid tissue. I'm going to parenthetically mention here that I think an area of collaboration that we have missed, and for the young folks out there, I'm going to challenge you to correct that mistake, has been more collaboration with our oncology colleagues. We have similar objectives of remission and cure, and we have similar challenges in getting drugs into either reservoirs or into tumors that may not favor drug penetration. And I think there's some opportunities that we're missing to collaborate with our oncology pharmacists, pharmacologists that some of the young crowd should take advantage of. So we think then, there is evidence that losartan has been, shown to formulate drug delivery in tumors. It's been shown to reduce collagen content, to reduce solid stress. All of these characteristics would improve vascular perfusion and thereby enhance intratumoral drug delivery. And this then provides, I believe, a biologically plausible mechanism for our observations that lymph node concentrations of these antiretrovirals did increase over time because of the presence of losartan. These enhanced concentrations then may have allowed the better suppression of HIV RNA in the lymph node, also the better suppression of the pro-inflammatory cytokines. So back to these principles. So I think the points we showed in the dolutegravir work that we intensified therapy, we changed conditions in a rectal compartment, measured markers of viral replication in peripheral blood mononuclear cells, and we saw those change. That if our principles here are correct, we should not have seen that unless there was ongoing viral replication. With the CSF work, we looked at a way to try to assess the potency of a regimen. Clearly, this ART IQ score is new. It needs more work. It needs more validation. But we did find regimens that had the higher IQ were associated with undetectable, non-detectable HIV DNA in the CSF. And then finally, with the lymph node work, again, another use of that ART IQ score to assess regimen potency and drug delivery that, again, we can show changes in the markers of virologic and immunologic effects. So, some key research goals to leave you with for remission or for cure. Cure, of course, remains a very aspirational objective, but there continue to be lines of evidence to pursue it, and this audience, I hope, will continue to do that. I think the two issues that are really important to pharmacology are the third one and fourth one. What are mechanisms that allow, HIV, or if you're doing macaque work, SIV control? And how, if ART does allow for ongoing replication, exactly how does it do it? Is it the potency of the regimen? Is it drug delivery to all places where you need to go? Is it some combination of other factors? And then, really some of our standard bedrock principles of therapeutics. Are we using the right therapeutic at the right time and the right potency? Does it have the safety therapeutic index that we need? And what about things that are going to enhance the efficacy of those drugs? So plenty of work I think for the future. So Going forward, I was a big X-Files fan when that was a popular show in the United States. I won't tell you how long ago that was, but the truth is out there, so it's up to you to continue to pursue it. From Freeman Dyson, a philosopher, that our obligation is to prove conventional wisdom wrong and make unpredictable dreams come true. And I picked two of our colleagues in oncology, Bill Evans and Mary Relling in 1999 wrote in Science that the traditional strategy of developing medications that are safe and effective at a fixed dose for every member of the population is a pharmacologic long shot because of highly potent medications, genetically diverse people, and diseases that have heterogeneous subtypes. So this is a picture of the first international clinical pharmacology conference held in Noordwijk in March of 2000. If you look hard, you will see some people in this photo who are still here in this room. I can find Courtney Fletcher standing over in the corner. I can find, but right in the center is Charles Boucher, who David already acknowledged as the person who had the idea for this conference. And here we are, 20. Steve Taylor, you are there. Did you find yourself? Yeah, you still look good. So. So Charles is one who had the idea for this conference, and that we're still here 26 years later shows you how right he was at the time about the need for this conference. So this is a photograph when we had this meeting in Budapest. One side of the table, Charles there sitting in the middle. For some reason, he's positioned under Attila the Hun. I don't think that was a fair characterization at all, but that's where he is with a glass of wine in his hand. There's the old saying, I guess it's more appropriate in the United Kingdom, about carrying coals to Newcastle. You don't need to bring coals to Newcastle. I don't need to say things, particularly in Amsterdam, to my Dutch colleagues about Charles. But I'm going to, take personal prerogative and say a few words of my feelings and thoughts about Charles. As David said, he was a physician, a virologist, a scientist, a collaborator, an educator, a mentor, always, always, always open to new ideas. Charles loved a good debate. And so nothing made him happier, I think, about having a good scientific debate. He also enjoyed a good glass of red wine, and you can see that in this picture. So Charles would clearly have been pleased that we're here 26 years later at this meeting, discussing science, discussing patient care, having some good debates, whether they're in the room or they're out in the hall over coffee or at the posters. And I think he would also be pleased that he can see the leadership of this meeting being passed to the next generation. So my closing words are your challenge then: go home, do good work, and come back next year. So this, the opportunity, the invitation to present this lecture is, I really can't, excuse me, really can't tell you how much it means to me. So thank you very much.